Let's begin. This afternoon, we'll be talking about Colles fracture. Okay, now it is being recorded. Does anyone know what a Colles fracture is? Ever heard of a Colles fracture?
I think it's
Fracture of the distal radius. Yes, that's correct. When you fall on the outstretched hand, yes. So this is an example of a Colles fracture. Right. And this is where the fracture is, the distal radius. You may have an associated fracture with the distal ulna, but by definition, a Colles fracture is a fracture of the distal radius. Now, how do you get a Colles fracture? It's by falling on the outstretched hand. That's how you get a Colles fracture. Fall on the outstretched hand. Right. Right. So fall on the outstretched hand, and the force is applied to the length of the forearm with the wrist in extension. And the fracture occurs transversely at the junction of the corticocancellous junction. All right. At the corticocancellous junction, which is where you're seeing this here. And this is what you end up with. Fracture of the distal radius. Right. And classically, the fracture is said to have a dinner fork deformity. And here you can see the classic dinner fork, and you can transpose that here and see the deformity that you get of the wrist. And this description was done before X-rays were invented. So that's the classic deformity you get with a Colles fracture. Now, Colles fracture, by definition, as I said, occurs at the distal radius within an inch of the wrist. And the typical mechanism is fall on the outstretched hand with the wrist extended. And it tends to occur in young individuals because of high energy trauma, while in older individuals, it tends to be low energy as a result of osteoporosis. Now, classically, Colles fracture occurs in postmenopausal women because of the onset of osteoporosis. Now, the classic features, it occurs in the distal radius, and the distal fragment is dorsally displaced and radially displaced as well. And you have what we call impaction. You may or may not have an associated ulnar fracture. This is a dorsal displacement. So this is the back of the wrist, dorsal displacement, and it's displaced radially. And it's displaced radially because of the pull of the brachioradialis muscle, which is attached to the distal radius. Right. Now, whenever a patient presents to you with a distal radial fracture, or Colles fracture as we call it, with the classic findings, then you need to examine the patient to ensure that there are no associated injuries. And the associated injury that you can get is what we call an acute carpal tunnel syndrome, where you can have compression of the median nerve and you get numbness and tingling in the fingers that are supplied by the median nerve. And so you need to examine your patient appropriately who has had a Colles fracture to ensure that they do not have the acute compartment syndrome. Following that, then you would get radiographs, and radiographs will show you what the fracture is like, and then you'll have to decide whether you can reduce this fracture or not. But whatever the position, we usually try initially to reduce the fracture. Now, to reduce the fracture, you need to administer analgesia. And analgesia may be administered in the form of what is demonstrated here, what we call a hematoma block, where you inject the fracture site with a local anesthetic, usually lignocaine or marcaine, so that you anesthetize the area. Alternatively, you may opt to do a regional block by using what we call a Beer's block, B-I-E-R apostrophe S, a Beer's block, where you inject in the vein a dilute solution of a local anesthetic, for example, 0.5% of lignocaine with a tourniquet attached to the arm so as to prevent the escape of the local anesthetic in the vein into the general circulation. And this Beer's block will cause numbness of the arm, forearm, and hand so that you can do your manipulation. And you have got to manipulate the fracture such that you reduce it. Notice the distal fragment is radially displaced, not ulnally, radially displaced. You've got to get it back in line. All right. So once you have reduced it, then you need to put it in what we call a back slab, which is half of a plaster, as demonstrated here. So the plaster is on the back of the hand, back of the forearm, and usually it is in a certain amount of flexion as demonstrated here, and a certain amount of ulnar deviation pointing towards this side now so as to overcome the pull of the brachioradialis. Once you have your fracture reduced, then you'll need to repeat the x-rays that have been done so as to confirm that you have appropriately reduced the fracture. The back slab is maintained for approximately 2 weeks, and we keep the back slab on because after the fracture we expect a certain amount of swelling, because this is a traumatic event, and the response to trauma, you do have inflammation and you do have the cardinal signs of inflammation: rubor, calor, dolor, tumor. Right, so you need to accommodate the amount of swelling that you get. So you put them in a back slab along with a sling which goes around the neck so as to keep the arm and hand elevated so as to decrease the swelling of the hand. Notice that your metacarpophalangeal joints are left exposed so that you can actually bend your fingers and help to decrease the swelling of the forearm. After approximately 2 weeks, when we expect that the swelling will have subsided, then we place our patients in a complete plaster, which is completely surrounding the arm. Okay, again, your metacarpophalangeal joints are exposed so that you can bend. Your thumb is also as well, and the plaster goes up towards the elbow. So this is a classic Colles type of plaster.
And they're both at the same side, so what should I do?
And the plaster is kept on for a total of 6 weeks from the time of injury, and at that point the plaster is removed.
You have to go to Western Union today?
The plaster is removed and you get a repeat x-ray.
Excuse me, Doc.
To demonstrate the amount of healing that has taken place. Because the wrist has been in a plaster for 6 weeks, you do expect a certain amount of stiffness of the wrist. And that's why we send our patients to get physical therapy. So physical therapy to get the wrist going after the removal of the plaster. And also to improve the strength of the wrist and your grip strength, increase the range of motion of the wrist, both dorsiflexion, palmaflexion, radial deviation, ulnar deviation, to get back the normal movement. So Colles fracture treatment, generally in a plaster for about 6 weeks, following which it's removed and you start your mobilization with physical therapy. Now, what are some of the problems that can be faced with Colles fracture? As I mentioned before, you can have what we call the acute carpal tunnel syndrome, where there's compression of the median nerve as it passes through the carpal tunnel as a result of the swelling that you get. You can get also delayed union of your fracture. If you are not appropriately reduced, you can get malunion, and very rarely do you get non-union. And I say very rarely because the area of the bone that is fractured is metaphyseal bone, which tends to heal much more than does fracture of the diaphysis. Other complications that you can get: rupture of the tendon of the extensor pollicis longus. The tendon of the extensor pollicis longus is on the dorsum, that's the back of the wrist. And you'll learn these terms: dorsum, meaning the back, or the volar surface, meaning the front of the wrist. So rupture of the tendon of the extensor pollicis longus, and that tends to happen later on, about 2-3 months, as a result of damage to the blood supply to the tendon in this region. It can rupture. And you can get, well, of course, if it does rupture, you have to go in and repair the tendon and address that. You can also get another condition which we call a reflex sympathetic dystrophy, RSD, or sometimes referred to as complex regional pain syndrome, where you get pain, swelling, stiffness of the hand, wrist, and to a lesser extent the forearm. This can be quite a dramatic condition when it does occur, in that the patient is unable to make a fist, they have severe, significant pain, swelling, and inability to use the hand. And it can last for a very long time and can give rise to permanent stiffness of the wrist. Reflex sympathetic dystrophy, abbreviated RSD, and complex regional pain syndrome. Very dramatic when it does occur. So that in a nutshell is Colles fracture. Now, not all Colles fracture can be treated non-operatively, and some may have to be treated operatively based on the extent of the injury. And unfortunately, so we might have to operate on patients who have got a Colles fracture. And in operating on them, we might have to use plate and screws. We might have to use K-wires. K-wires are small wires which are used to drill through the bone to hold the bone in position once you have reduced it. Or we might have to resort to what we call an external fixator. And external fixators are used especially when you have got a significant amount of comminution of the fracture, where there's significant shortening. And so you put on an external fixator, which goes from the finger, usually the metacarpal, the second metacarpal, and to the radius spanning the wrist so as to hold it in position. And you can use K-wires with an external fixator to hold it in position and to allow it to heal. This is an example of plate and screw fixation, fixing a distal radial fracture. So the plate is here on the volar surface, on the front of the wrist, the volar surface, and it's supporting the bone, and the screws go through on the back. Plate and screws. And notice the shape of the plate. We commonly refer to this as a T buttress plate because of the shape, like a T buttress plate. And that holds the fracture in position until it heals. So that's Colles fracture in a nutshell. All right. You may come across other fractures, and I'll just run through those of the end of the radius. You may hear about a Smith fracture, where the fracture, not on the outstretched hand now, but you fall on the back of the hand, on the dorsum of the hand, and you get essentially an opposite fracture to a Colles fracture. You may get also what we call a Galeazzi fracture, where there is a fracture of the distal third of the radius and disruption of the distal radio-ulnar joint. Normally, the radius is longer than the ulnar, But having had a fracture here, you can see that the ulna is much longer than the radius because the joint, the distal radial ulnar joint has been disrupted. That's called a Galeazzi fracture. So another example of the Galeazzi fracture, distal third, disruption of the inferior radial ulnar joint. All right. This is what the normal is like, where the radius is longer, but in a Galeazzi fracture, you get disruption of the distal radial ulnar joint, and so the ulna becomes longer. And the treatment for this is plate and screws, plate and screws, and you put wires across to hold the ulna to the radius so as to keep the radial ulnar joint reduced. And once this has healed, then you remove your wires, and usually about 6 weeks, 6 to 8 weeks before these are reduced. Right. The other fracture that you'll come across is called a Monteggia fracture. A fracture of the proximal third of the ulnar this time, with disruption of the proximal radio-ulnar joint. Proximal radio-ulnar joint disrupted. A Monteggia fracture. Remember, the head of the radius articulates with the capitellum. Head of the radius articulates with the capitellum. Therefore, this ought to be down here. But in this type of fracture, it is dislocated, and so you'd have to treat this again with plate and screws, and this will come back down. So you've heard of a Smith fracture, you've heard of a Monteggia fracture, you've heard of a Galeazzi fracture. Right. This is an example of a distal radial fracture that was treated in the back slab with just this is the dorsum of the wrist, or the back of the wrist, and that's where the back slab is, a plaster. Notice plaster, very white on the film. Okay, so that's Colles fracture. Now, the talk is Colles and other fragility fracture. What do we mean by fragility fracture? We're essentially talking about osteoporosis. Osteoporosis. What's the definition of osteoporosis? It's a bone mineral density, BMD, which is greater than 2 Osteoporosis is a systemic disease characterized by low bone mineral density and deterioration of your microarchitecture with resultant increased fragility and the tendency to fracture. And its definition is 2.5. Sorry about this. This is 2.5 standard deviations below the mean of a young adult that is used as a reference. Okay? The bone mineral density is greater than 2.5 standard deviations below the mean of a young adult. And the young adult is expected to have a normal bone mineral density. What are some of the predisposing factors to osteoporosis? Remember, we said Colles fractures tend to occur in postmenopausal women. But it can occur in men, but postmenopausal women are the ones who are most likely to get Colles fractures. And it's as a result of their bone mineral density being below 5 standard deviation, below the mean of the young adult. Predisposing factors for osteoporosis, race. The Caucasian race tend to have osteoporosis than the Negroid race. Females tend to have lower bone mineral density than do males. If you have got a low BMI, body mass index, then you're more prone to developing osteoporosis. If you drink a lot, alcoholic, you are more likely to have osteoporosis. If you smoke, you're more likely to have osteoporosis as well. And if you've got a late menarche, where onset of your period start late and menopause start early, you're more likely to develop osteoporosis. And of course, thyroid dysfunction can also give rise to osteoporosis. Okay. Now, what are the bones that are affected in osteoporosis? We've already looked at the distal radius. The other bones that are affected primarily are the hip bone and the spine. You will be having a session dealing with hip fractures, especially. And for now, we will go through and talk about and just have a look at some of the affected areas, the bones affected, and how you investigate and treat osteoporosis. This is an example of someone who has got a vertebral fracture as a result of osteoporosis. If you look at the outline of the bone, that's a vertebra. Right. And look at the one below. All right, so that's the outline. This one, however, has a fracture. And so you can appreciate how compressed this vertebra is when you compare. And as you go down the spine, the vertebrae increase in size. So this one is quite small. This is the one beneath it. And this is what it looks like on the lateral film. Yep. It has a wedged shape. Okay. Again, you can see it here, much more clearly outlined. The wedge shape of the vertebra. And here is another one. Right, hip fractures. A number of areas. Hip fractures tend to occur in the elderly when they fall, or they may just twist and the bones break before they fall. And we usually classify fractures here would be subcapital. Capitis is a head, sub meaning below, below the head, subcapital fracture. This is a transcervical, across the neck, transcervical. You also have another group of fractures we call basicervical fracture at the base of the neck. you've got the intertrochanteric between the greater trochanter and the lesser trochanter, and you have the subtrochanteric fractures. So these are the fractures that you are likely to come across, and as I said, you will have a full lecture on fractures of the neck of the femur, which is a very common condition that you see in orthopedics. If you come on the ward, you will certainly see at least 3-4 patients who have got fractures of the hip. It is a very common condition that occur in the elderly population. And as I said, it occurs as a result of osteoporosis, decreased bone mineral density. And the areas that are affected most often, the distal radius with the Colles fracture, the spine, and the hip. Right? Osteoporosis, often referred to as a silent killer because it tends to come on insidiously. It doesn't tend to give you much warning, and especially as it relates to the hip, some studies have shown that having broken your hip, up to a third of patients are likely to die within a year of having had that hip fracture. So that's why it's called a silent killer. And a third die within a year, and a half of them are incapacitated. They cannot walk without support, and they can't climb stairs, can't go up and down stairs. And of course, those who used to live on their own, a significant number of them are unable to return to living on their own, and so they have to be in a nursing home or a nursing care residential facility for a very long period of time. So osteoporosis is a very, very common condition that you need to be mindful of and think about it, especially when patients come in with any of the 3 fractures that I have mentioned: a Colles fracture, vertebral fracture. The significant thing about the vertebral fracture is they tend not to present dramatically. They tend to have chronic back pain, and it's when you x-ray them that you are likely to see that they have vertebral fractures. Again, because it's what is referred to as a silent killer. Okay, so how do you treat osteoporosis? Because it is, well, prevention is better than cure, and it starts in childhood. Right? You eat right, you drink right, try and avoid carbonated beverages, which tend to decrease your bone mineral density, and you exercise right so that you build your bone density to the maximum. Eat right, drink right, and exercise right. Okay? And if you do develop osteoporosis, then there are a number of treatment options: calcium supplements, vitamin D, hormone replacement therapy, bisphosphonates, calcitonin, fluorides, and of course you have to ensure that you have an adequate diet which is rich in calcium. All right. So, as you know, most people live beyond 70 years, and so osteoporosis will become a major problem. Prevention is better than cure, so we need to educate our young people in particular about exercise, eating right, so that you attain a high bone mass or bone mineral density, and you maintain that. Especially for females, once you pass the menopause, then you're likely to start losing bone mass. Nothing you can do about that, but that's how it is. Unfortunately, I will have to stop at this point because, as I said to you, I have to be on another session. Okay? Thank you. You're most welcome. Okay.